Hello, welcome to Pathagonia. Today we're going to use Kurt's notes to talk about cardiac pathology. Before we begin, if you already haven't, check out Kurt's Notes website where you can access Dr. Schaberg's Kurt's Notes. And recently there's been an article describing the impact Kurt's Notes has had on medical education. Did you know that in the average week over 4,000 users access Kurt's Notes, with approximately 1,000 users on a typical workday? So I encourage you to read this article when you have the chance. Without further ado, let's talk about myocardial vascular conditions. Myocardial infarction, aka MI. This is due to ischemia that leads to irreversible coagulative necrosis of myocardium. It's usually due to an acute thrombus overlying unstable atherosclerotic plaque. This leads to necrosis of myocytes, and this leaks troponins and other cardiac enzymes. It's detected in serum, which distinguishes between angina and MI. The timing of pathologic findings, which is important for boards as well as forensics in particular, in 0 to 2 days, you'll have hypereosinophilic myocytes. Less than 5 days, you'll have mostly neutrophilic inflammation and coagulative necrosis, quote unquote acute. Grossly, it'll look pale yellow. Approximately 1 week, it starts healing with granulation tissue and fibrosis, quote unquote subacute. Grossly, it'll look pale with a hyperemic border. 1 to 3 months, it'll look healed with dense fibrous scar. If reperfused, then there'll be hemorrhage and prominent contraction bands, as you can see here. Arteries are in the epicardium, so the first most impacted areas are subendocardial because that's the furthest away from the blood supply, and most fatal MIs are transmural. Potential complications: death, most often from arrhythmia, ventricular wall or papillary muscle rupture, pericardial effusion, which is Dressler syndrome, and heart failure. Coronary atherosclerosis, aka coronary artery disease, CAD. This is development of atheromatous plaques in coronary arteries. The process will begin with endothelial injury inflammation. This leads to accumulation of lipoproteins. These are ingested by macrophages, and there will be foamy macrophages in intima, quote unquote xanthoma, with a fibrous cap, calcifications, and smooth muscle proliferation. This gradually grows and narrows your lumen. This can rupture and triggers thrombosis of rest of lumen, and this leads to ischemia and myocardial infarction. Risk factors include obesity, diabetes, smoking, hypercholesterolemia, male gender, hypertension, and inflammation. Ventricular hypertrophy. This is an adaptive response to increased load on the heart. Common causes include systemic hypertension and aortic stenosis. Grossly, the wall thickness is greater than 1.5 centimeters. Microscopically, you're going to have myocyte hypertrophy, which look like boxcar square nuclei with interstitial fibrosis. You'll have increased risk of ventricular arrhythmias and sudden death. Hypertrophic Cardiomyopathy. This is a relatively common cause of sudden cardiac death, particularly in young adults with exertion. Frequently have mutations of sarcomere proteins and often autosomal dominant with incomplete penetrance. It's common, approximately 1 out of 500 people. Grossly, you'll have enlarged heart with thickening of the ventricular walls, particularly the interventricular septum. Microscopically, you'll see myocyte hypertrophy, as well as disarray of the myofibers on taking cross-sections of the ventricular septum, and interstitial or pericellular type fibrosis. This can lead to outflow obstruction, quote unquote HOCM, or hypertrophic obstructive cardiomyopathy, and or arrhythmia. Dilated cardiomyopathy. This is a 4-chamber dilation in the absence of significant valvular, ischemic, or hypertensive disease. It can be primary due to genetics or familial, where multiple genes are implicated, or secondary to other disorders like post-inflammatory, medication-induced, peripartum, endocrine, nutritional, or alcohol. Left ventricular dilation is greater than 4 centimeters. You'll have dilated atria, normal to mildly thickened walls, and nonspecific microscopic findings. You can have fibrosis and variation in fiber size. And you can see here, the left ventricle is greater than 4 centimeters. Arrhythmogenic Cardiomyopathy, aka arrhythmogenic right ventricular dysplasia / cardiomyopathy. Classically, you'll have right ventricle as you can see here, infiltrated by fat and scar with aneurysm formation. It's going to lead to arrhythmias and conduction disturbances, leading to sudden cardiac death. Actually, both ventricles are often involved. Multiple genes are implicated and can be familial. Left ventricular noncompaction. You'll have prominent ventricular trabeculations, as you can see here, where it looks like beams connecting to each other, where it looks like your trabecular bone. You'll have deep trabecular recesses and a thin compacted layer, mostly involving the left ventricle. It's most common in infants and kids and associated with other congenital heart problems, and it can lead to heart failure, arrhythmias, and embolic events. This is a question I recall I had on one of my practice board questions. Myocarditis. This is inflammation of the myocardium with myocyte degeneration / necrosis, not due to ischemic coronary artery disease. You can have the most common form of myocarditis is the lymphocytic myocarditis. It's usually in children or young adults. Diagnosis is often made based on clinical findings, usually attributed to viruses, most commonly Coxsackie viruses and adenoviruses. It's often you'll see diffuse infiltration of myocardium by T cells. Most patients respond to anti-inflammatory medication, but a subset progress to dilated cardiomyopathy, and this can cause arrhythmia, leading to sudden death. Differential diagnoses include Lyme disease and collagen vascular disease. Eosinophilic myocarditis. This is myocarditis with documented tissue or peripheral eosinophilia, often allergic or hypersensitivity associated. Rarely it's due to parasites. You have minimal damage and usually attributed to medications. Giant cell myocarditis. This is rare, idiopathic, likely autoimmune, and generally seen in young adults. You'll have a rapidly deteriorating course. Histologically, you'll see diffuse infiltration of the myocardium by a mix of lymphocytes, eosinophils, occasional neutrophils, and prominent giant cells. These are not granulomas as seen in sarcoidosis, and you can have diffuse necrosis. Speaking of sarcoidosis, most have systemic involvement. Histologically, you'll have well-formed, hard/tight granulomas with fibrosis. It may have some associated lymphocytic inflammation, and this leads to interruption in the conduction, leading to heart block and arrhythmias and sudden death. Amyloidosis. This is usually part of a systemic disease. As a reminder, amyloidosis is the deposition of misfolded proteins, leading to restrictive cardiomyopathy, arrhythmias, conduction disturbances, and/or congestive heart failure. Grossly, you'll have a large, firm, rubbery, or waxy heart. All amyloid is highlighted by Congo red stain, and if you do birefringence, it'll be apple green. On trichrome stain, it appears grayish, and you could do subtyping based via mass spec or immunofluorescence to help determine the cause, to potentially treat the underlying disease that causes. Transplant pathology. Transplant patients are frequently monitored with transjugular surveillance biopsies, the Quilty effect. These are nodular endocardial infiltrates, as you can see here, and seen in approximately 10 to 20% of transplant biopsies. Predominantly lymphocytic with central B cells and dendritic cells. It's not rejection, but weakly associated with rejection. As opposed to rejection, which is T cells within the myocardium, this is endocardial, with B cells and dendritic cells. And fun fact, this was named after a patient who often had these in their biopsies. Acute cellular rejection, usually weeks to months after transplantation, but can occur years after if insufficiently immunosuppressed. You'll have infiltration by T lymphocytes with myocyte damage, and it must be within muscle or in a perivascular location. It may be asymptomatic or present with graft dysfunction. You can do an IHC panel to further evaluate rejection, including CD3, 4, 8, 20, 68. Acute cellular rejection infiltrate is CD3 positive T cells, including both CD4 and CD8, with occasional macrophages, CD68, and rare eosinophils. Quilty effect. You'll have mixed in B cells with CD21 positive dendritic cells. Ischemic changes, mostly neutrophils and histiocytes, and few lymphocytes. biopsy site, mostly macrophages with B and T cells and disorganized myocytes with scarring. Post-transplant lymphoproliferative disorder, mostly B cells, infection, and mixture of T and B cells. And you can grade using the ISHLT grading system, where it's graded from 0R to 3R, and we'll leave this here for your review. Antibody-mediated rejection. This is complement-mediated endothelial damage. You'll have endothelial activation, where you'll see big swollen endothelial cells with immune complement deposition. You'll see intravascular macrophages that are CD68 positive. You should have no significant lymphocytic inflammation. You can identify complement deposition in the capillaries with C4D staining, as you can see here, looking for diffuse subendothelial capillary positivity, and it can coexist with acute cellular rejection. They're not mutually exclusive, and clinically have donor-specific antibody. Usually it's seen in the first month after transplant, but can happen later too. And the grading scheme is from 0 to 3. And for your review, Allograft Vasculopathy, essentially the cardiac version of chronic rejection. This mainly impacts arteries, only seen at autopsy/explant. You'll have concentric diffuse vessel wall thickening and lumen narrowing by intimal hyperplasia with smooth muscle with mild chronic inflammation. And inflammation involves all layers of vessel. It can lead to thrombosis and/or chronic ischemia or infarction with fibrosis, the main limitation to long-term success of transplantation. Valvular disorders, degenerative valve disease, or calcific degeneration. This impacts the aortic valve and mitral annulus, left-sided mostly. It clinically presents with stenosis and/or insufficiency. You'll have histologically fibrotic thickening and nodular calcifications. You may see sparse chronic inflammation. It's especially common if there is a bicuspid aortic valve, and you'll treat with valve replacement. Myxomatous/myxoid degeneration. This impacts the mitral valve and aortic valve, mainly left-sided. You'll have replacement of collagen with mucopolysaccharides, particularly in the central spongiosa layer. Grossly, it'll look like floppy, translucent leaflets. This will lead to mitral valve prolapse and insufficiency and regurgitation. Aortic myxoid degeneration is often associated with secondary to a dilated aortic root. It's still unclear etiology, genetics, and pathogenesis. And mitral valve prolapse is more commonly seen in females. Rheumatic disease. During acute rheumatic fever due to group A streptococci infection, this can lead to pancarditis, where all the layers of the heart are involved. Classic findings include Aschoff nodules, which are round histiocyte-rich lesions within the myocardium. Afterwards, this can lead to scarring of the mitral and aortic valve, secondary to an autoimmune reaction, and you can get mitral stenosis plus minus insufficiency, leading to pulmonary hypertension and over time right ventricular hypertrophy. You'll have marked valve fibrosis with commissural fusion and thickened chordae, and classically looks like a fish mouth grossly, and have non-specific histologic findings. Endocarditis. More particularly for infectious endocarditis, you'll have bacteria or fungal infection of the endocardium. In most cases, primarily involves the valves, and most common culprits are staph and strep species. Vegetations histologically consist of fibrin with neutrophils and microorganisms, plus or minus valve destruction. If you see neutrophils and fibrin on a valve, order bug stains to rule out infectious endocarditis. Non-bacterial, thrombotic, or merantic endocarditis refers to the presence of sterile thrombi on heart valves due to abnormal flow and/or hypercoagulable states. Carcinoid heart disease is due to secretion of serotonin and related products from a well-differentiated neuroendocrine tumor, usually from a small bowel tumor with liver metastasis. It causes right-sided fibrous endocardial plaques on the leaflets of tricuspid and pulmonary valves, leading to right-sided heart failure. Tumors. Primary heart tumors are rare. Even though the majority are benign, they can interfere with the heart's mechanical or electrical functions and present with sudden death. The most common cardiac tumor is Papillary Fibroelastoma, which grossly resembles a sea anemone, as you can see here. It's a benign endocardial neoplasm. Architecturally, you'll see papillary branching fronds covered in endothelium. It'll have an avascular core with collagen and elastin, and usually arises on the valves on the left side of the heart. A subset have KRAS mutations, so seem to be neoplasms, although prior was thought to be a reactive condition due to trauma. It may be incidental, and if symptomatic, it may be due to obstruction or embolization. Cardiac myxoma. This is the second most common heart tumor. It's a benign intracavitary endocardial lesions, usually in the left atrium. Histologically, you'll see bland, stellate to plump spindled cells or myxoma cells within a vascular myxoid matrix. You may see inflammatory cells, giant cells, hemorrhage, hemosiderin-related macrophages, calcifications, bone, and glandular appearing elements as well. The matrix stains with PAS and Austrian blue, and a myxoma cell stained with calretinin. It may be pedunculated, sessile, or villiform and can arise in the setting of Carney complex. If symptomatic, usually due to obstructing blood flow or embolization. Recurrence after resection is relatively rare. Cardiac fibroma. This is benign, usually in ventricular septum of children. You'll have bland fibroblasts, invariably collagenized stroma. Although grossly circumscribed, microscopically may infiltrate myocardium. Microcalcifications are common. IHC, it'll be positive for smooth muscle actin, and often large and can interrupt conduction/contraction. It's associated with Gorlin syndrome or nevoid basal cell carcinoma syndrome due to germline patch 1 mutations. Cardiac rhabdomyoma. This is benign. It's most common in ventricular myocardium of children. You'll have histologically vacuolated large spider cells with radial sarcoplasmic extensions from the nucleus to the membrane. Most common cardiac tumor in children, and it's thought to be a hamartoma of developing myocytes. It'll be positive for desmin and actin, and the PAS highlights glycogen. Often arises in the setting of tuberous sclerosis, which is germline mutation either due to TSC1 hamarin or TSC2 tuberin mutations. Other tumors include metastasis. This is the most common by far. Most commonly lung cancer, also frequent are melanoma, sarcoma, renal cell carcinoma. Other tumors that can be seen in the heart, lipoma, which are benign encapsulated proliferation of mature adipose tissue. If in the atrial septum with brown fat and mature fat and atrial myocytes, this is lipomatous hypertrophy of atrial septum. Adult cellular rhabdomyoma, just like in the head and neck, it's a benign neoplasm of striated muscle. It's a cellular proliferation of round to spindled cells with prominent vascularity. It's in adults and not associated with tuberous sclerosis. Hemangioma, this is a benign proliferation of thin-walled vascular spaces without atypia. Angiosarcoma, malignant cells with vascular differentiation. It's the most common cardiac sarcoma. Leiomyosarcoma, undifferentiated pleomorphic sarcoma or UPS. And DLBCL, or diffuse large B-cell lymphoma. Very rare cardiac tumors include lipomatous hamartoma of the atrioventricular valve, where you'll have unencapsulated fat in AV valve. Hamartoma of mature cardiac myocytes, which is a discrete nodular collection of disorganized myocytes forming a mass. Mesenchymal cardiac hamartoma. This is discrete collections of mature mesenchymal tissues in the heart. Conduction system hamartoma, you have collections of pale eosinophilic Purkinje cells distributed along endocardium, usually identified in kids. You have arrhythmias leading to sudden death. Cystic tumor of the AV node. You have endodermal inclusions forming a cystic lesion within the AV septum. Well, thank you so much for listening and watching, and we'll end this with a rapid review. Cardiac pathology, myocardial, vascular conditions. You have MI from ischemia leading to irreversible coagulative necrosis of myocardium, and often due to an acute thrombus overlying an unstable atherosclerotic plaque. The timing of pathologic findings from 0 to 2 days, you'll have hypereosinophilic myocytes, less than 5 days, mostly neutrophilic inflammation and coagulative necrosis, which is acute. Grossly, it'll be pale yellow. 1 week, it starts healing with granulation tissue and fibrosis, or subacute, and grossly, it'll be pale with hyperemic border. 1 to 3 months, it'll be healed with dense fibrous scar. If reperfused, you'll have hemorrhage and prominent contraction bands. Coronary atherosclerosis, development of atheromatous plaques. And this plaques can rupture, triggers thrombosis of the restive lumen, leading to ischemia and myocardial infarction. Risk factors include obesity, diabetes, smoking, hypercholesterolemia, male gender, hypertension, inflammation. Ventricular hypertrophy, adaptive response to increased load. Common cause includes hypertension. Microscopically, you'll see these boxcar-like nuclei from myocyte hypertrophy. Hypertrophic cardiomyopathy can lead to sudden cardiac death in young adults, particularly with exertion. You'll see enlarged thickening of the ventricular walls, particularly the interventricular septum, and you can see myocyte hypertrophy, myofiber disarray, and interstitial fibrosis. Dilated cardiomyopathy, this is 4-chamber dilation in the absence of significant valvular ischemic or hypertensive disease. It can be primary or secondary, and it'll have nonspecific microscopic findings. Arrhythmogenic cardiomyopathy, you'll have a right ventricle infiltrated by fat and scar. Left ventricular noncompaction, you'll have prominent ventricular trabeculations. Myocarditis, inflammation of the myocardium. The most common is lymphocytic myocarditis, often attributed to viruses, and you'll see diffuse infiltration of myocardium by T cells. Eosinophilic myocarditis, it's often due to an allergic or hypersensitivity associated, and they'll have peripheral eosinophilia. Giant cell myocarditis, it's rare, rapidly deteriorating cause. And you'll have a diffuse infiltrate of the myocardium by a mix of lymphocytes, eosinophils, neutrophils, and prominent giant cells. Sarcoidosis, you'll have these tight granulomas with fibrosis, which can interrupt conduction and lead to sudden death. Amyloidosis, usually part of systemic disease, and you'll have restrictive cardiomyopathy, usually part of systemic disease, and the deposition of misfolded protein can lead to restrictive cardiomyopathy, and it'll stain positive for Congo red and be apple green on birefringence. Transplant pathology. Quilty effect are nodular endocardial infiltrates, where you'll see predominantly lymphocytic with central B cells and dendritic cells. Acute cellular rejection, usually weeks to months after transplantation. You want to see infiltration by T lymphocytes with myocyte damage, and so it must be within muscle or in a perivascular location. And you can order CD3, 4, 8, 20, 68 to further evaluate rejection. And you'll grade using the ISHLT grading system from 0 to 3. Antibody-mediated rejection. You'll have complement-mediated endothelial damage and endothelial activation, where you'll see big swollen endothelial cells. You can see intravascular macrophages. There should be no significant lymphocytic inflammation, and you can identify complement deposition with C4D along the capillaries, and you should see diffuse subendothelial capillary positivity. Allograft Vasculopathy, essentially the cardiac version of chronic rejection, and it mainly impacts arteries. You have concentric diffuse vessel wall thickening by intimal hyperplasia with smooth muscle with mild chronic inflammation. Valvular disorders, you have degenerative valve disease or calcific degeneration. It impacts the aortic valve, and you can have clinically present with stenosis. You'll have fibrotic thickening and nodular calcifications. Myxomatous, myxoid degeneration, impacts mitral valve and aortic valve. You'll have replacement of collagen with mucopolysaccharides, and this can lead to mitral valve prolapse and insufficiency. Rheumatic disease. During acute rheumatic fever, you'll have pancarditis. Classic findings are Aschoff nodules or round histiocyte-rich lesions within the myocardium. Afterwards, you'll have scarring of the valves due to an autoimmune reaction, and this can lead to mitral stenosis and or insufficiency, pulmonary hypertension, and right ventricular hypertrophy. The marked valve fibrosis looks like a fish mouth grossly. Endocarditis. Infectious carditis is due to bacterial or fungal infection of the endocardium. In most cases, primarily involves valves. Vegetations consist of fibrin with neutrophils and microorganisms, plus or minus valve destructions. So if you see neutrophils and fibrin on a valve, order bug stains. and carcinoid heart disease. Tumors are rare. Most common tumor is papillary fibroelastoma. That looks like a sea anemone. You'll have papillary branching fronds covered in endothelium. Usually arrives on valves on the left side of heart. Cardiac myxoma. These are benign intracavitary endocardial lesions seen usually in the left atrium. It's the second most common heart tumor. Look for your planned stellate to plump spindled cells, your myxoma cells within a vascular myxoid matrix. And you may see inflammatory cells, giant cells, hemorrhage, hemosiderin-laden macrophages, calcifications, bone, and glandular appearing elements. Cardiac fibroma, these are benign, usually in ventricular septum of children. You have bland fibroblasts and variably collagenized stroma and associated with Gorlin syndrome. Cardiac rhabdomyoma, this is benign, most common in ventricular myocardium of children. You have vacuolated large spider cells with radial sarcoplasmic extensions from the nucleus to the membrane. It's thought to be a hamartoma, often arises in the setting of tuberous sclerosis. Other tumors include metastasis. Other tumors that can be seen in the heart, lipoma, adult cellular rhabdomyoma, hemangioma, angiosarcoma, leiomyosarcoma, undifferentiated pleomorphic sarcoma, DLBCL. Very rare cardiac tumors include lipomatous hamartoma of the AV valve, hamartoma of mature cardiac myocytes, mesenchymal cardiac hamartoma, conduction system hamartoma, and cystic tumor of the atrial ventricular node. Well, thank you so much for listening, and as always, thank you to Dr. Schaberg for his excellent notes. We'll see you on the next episode of Pathagonia. Bye.